Dear my friends, I'm Dr. Şengül Özdek from the Ophthalmology department, and I will talk about retinal detachment in this lecture. I would love to do this lecture face by face with you, but unfortunately, because of the pandemic reasons, we have to do this only in this virtual lecture. So I will stop my video after now. I just wanted to say hi with my view first, because the file will be very large if I don't stop the video. So I will continue like this after that. When we talk about retinal detachment, the first thing we should do is to talk about the retinal anatomy first. As you see here, retina starts from the ora serrata, and it goes towards the optic nerve head, and it's the inner coating of the globe. And in the center of the optic nerve head, you see central retinal artery and veins, and it supplies the inner layers of the retina, and the outer layers of the retina is supplied by the choroid. It's by diffusion. And this is a histological cross-section of the retina, and you see here, this is sclera, this is choroid from outer to inner layers. You see this one-layered cellular structure is called the retinal pigment epithelial cell layer. And this is a very active, physiologically very active cell layer, and they can do phagocytosis of the remnants of the photoreceptors, and they also form the outer blood retinal barrier with the zonular occludens, which is between the Rpe cells, and it has many functions like depositing the vitamin A and present it to the photoreceptors when they need it. So if the retinal pigment epithelium is died or is not alive, or if it is damaged, then the photoreceptors adjacent to them cannot survive, cannot function anymore. And the rest of the retina is called sensorial retina. When we look at the sensorial retina, it has many layers, but the first one is the photoreceptor layer, which is consists of rods and cones. And the outer layers are continuous with the inner nuclear layer, which is called outer nuclear layer. These are the nucleus of the photoreceptor cells. These are the cells which captures the vision. And then inner nuclear layer comes, and then the ganglion cell layer comes. So we have the first three nuclei of the visual pathway in the retina: photoreceptor cell layer, bipolar cells, and ganglion cells. And the axons of the ganglion cells forms the nerve fiber layer, and they come together at the back of the eye to form the optic nerve head. Optic nerve head consists of 1.2 million ganglion cell axons, and it's like 1.5 millimeter in diameter. And from the inner side, from center, the central retinal artery and vein comes. It divides into superior and inferior branches first, and then temporal and nasal branches. As you see here, the temporal branches usually curve, forming an arc in the temporal part, and in between these two superior and inferior temporal arcuate vessels, we call it as macular area between the arcuate vessels. And the macula is like 5.5 millimeter in diameter, and in the center of the macula we have fovea, which is again like approximately 1.5 millimeter in diameter, like the optic nerve head. And in the center of the fovea there's foveola, as you see here, which is 0.35 millimeter, which is 350 micrometer in the center of the fovea. This is important for the sharp vision. Sharp vision forms here. And when we look at the histologic section of this cross-section of this macular area, as you see here, foveola is the thinnest part of the retina. There's no other cell layer other than the photoreceptors here. There are one-to-one connection between the other cell layers, but they are pushed towards the sides. This is just to have the sharpest vision in this area, because we don't want even these cellular layers to block the sharp vision. And the other, there's only a cone cell here, cone cells only here. And when the retina goes towards the periphery, we have more rod cells in the periphery, but in the center, only cone cells. That's why the central retina is important for color vision and the sharp vision. And the histological, another important thing is that in the macular area, ganglion cell layer is more than one layer. In the other parts of the retina, it's just one layer, but it's multi-layered in the macular area. This is important to understand pathology of some of the diseases, findings of the diseases. You'll understand it later. So let's continue with the vitreous. You know, vitreous is the second important actor in the retinal detachment story. And vitreous is the main supporter of the retina. And it is a jelly-like structure, which is very similar to the white part of the egg, you can guess. And there's an outer lining, outer coating of the vitreous, which is called vitreous cortex or hyaloid membrane. And the 99% is the water, and there's type 2 collagen fibers in the vitreous, together with hyaluronan and glycosaminoglycan in between. So what's retinal detachment? It is separation of the neurosensorial retina from retinal pigment epithelium. But there are some powers holding the retina in place, and vitreous is the major one, which is the main power supporting the retina. The second one is the Rpe cells. The Rpe cells has an active ion transport system, which pumps any fluid which accumulates between the photoreceptor cells and the retinal pigment epithelium. It pumps that fluid towards the choroidal side, so that there is no accumulation between, causing retinal detachment. So these two are very important. There are three types of retinal detachment, and the first one and the most common one is the Rheumatogenes retinal detachment, which means retinal detachment with a retinal break. And the second one is directional retinal detachment, which needs a retinal traction to form. And this traction usually originates from a membrane, a contractile membrane. The cause of this contractile membrane is usually ischemic retinal diseases like diabetic retinopathy or retinal vein occlusions. And the third and the least common one is the exudative retinal detachment. And as the name implies, the exudate comes from the blood vessels. So the reason is usually caused by a pathology in retinal blood vessels or systemic conditions like eclampsia or pheochromocytoma, which cause hypertensive crisis, pushing the blood and serum against the retinal endothelial cells. So let's start with Rheumatogenes retinal detachment. The risk of retinal detachment in normal human life is like 3 to 4%. But when you have a retinal detachment in one eye, the second eye risk is more. It's like 10%. So bilaterality is common. And the most common ages are usually after 40, like 50, 60 years of age. It develops in 3 stages. The first thing is the posterior vitreous detachment, because vitreous support is lost with this detachment. And the second step is formation of a retinal break. And the third step is retinal detachment. You know, detachment is separation of the sensorial retina. So why vitreous separates? It starts with vitreous degeneration. Vitreous normally starts to liquefy after 40 years of age, and it starts more earlier in myopics, and this is called synthesis senescence. It forms some liquefied spaces in the vitreous cavity. They come together to collapse, and then they go under the posterior hyaloid surface, and it causes detachment of the posterior hyaloid from the retina. We call it as posterior vitreous detachment because the base part, which is the anterior-most part of the vitreous, is very strictly attached to the retina. So it never detaches from the anterior part. That's why we call it posterior vitreous detachment. It starts usually from the perifoveal area, which is called stage 1, and then fovea detaches, and then since the optic nerve head area is strictly stuck, the nasal part starts to detach, and then it detaches from the optic nerve head. This is called stage 4. This is the last stage. We can also monitorize this posterior vitreous detachment with the OCT, which is optical coherence tomography, which is an equivalent of ultrasonography, but it takes like 70,000 sections, mode sections of ultrasonography, and it has a histological-like structure. As you see here, we can see all the layers and also the posterior hyaloid. You see there's a very small beginning of posterior hyaloid detachment. This is the perifoveal detachment, like in stage 1. And then if it doesn't detach from fovea, it may cause an abnormality, which is called vitreomacular traction. It's a complication of PVD, and in this situation, vitreous vision may start to deteriorate, or it may just detach to form the stage 2 PVD, as you see here, and in the optic nerve head area, it is still attached. So, there are some stronger adhesion sites like vitreous base, as I told you before, and also the optic nerve head area. It's attached to the optic nerve head area with a fibrotic membrane called Weiss membrane. I will show it later. Fibrotic membrane, so it's more strongly attached, and it's also more strongly attached macula and retinal big vessels, and around the peripheral retinal degeneration areas, which I will talk later. PVD occurs more in elderly patients, and it increases with age, and 65% of patients have PVD at age of 65 and increase with age. And it occurs earlier in myopics and in patients having cataract surgery. So, and also following ocular trauma. So these things make the PVD to become earlier. As you see here, when the vitreous detaches, you see the Weiss ring detaches from the optic nerve head area, and it comes into the view. So they may feel like there is something flying in my view. They call it like there's a spider-like thing in my view, moving all the time with my eye movements. It's called floaters. This is very, very typical of posterior vitreous detachment. They may also feel flying flies everywhere, like in this picture, these two pictures. But I can hear your voice that I have such things in my eyes. This is very normal because during the routine vitreous aging, since you remember, we have some vitreous vitreous liquefaction procedure. So the collagen fibers in vitreous comes together and leaving the liquefied water part separately. Then those collagen fibers come together to form some fibers like these things here. And you can see these things when you look at the white area in the very good lightened area, then you can feel those things flying in your view. So this is normal, this is routine, it occurs more in myopies. But when you feel these things, millions or hundreds of flying objects coming into your scene suddenly, that means that it's something different. So I'm talking about this symptom as floaters. So these flying flies comes into your view suddenly, and in many of them comes. So this is called floaters. And photopsia may also accompany this, which is flashes of light. You can, the patients can feel these flashes of light in a dark room, or in a dark room they can see that the flashes are coming and going, or a light is coming and going, turning on and off. They feel like that. These two things are very typical of posterior vitreous detachment. So in this lecture, you should never forget this, please. You should learn this. Photopsia and floaters are the main symptoms of the posterior vitreous detachment. But I should say that these are, most of these patients do not feel anything. It's usually asymptomatic. But when they are symptomatic, they feel photopsia and floaters. Please don't forget this. So, although this is a routine thing with aging, this posterior vitreous detachment may cause some complications like a retinal tear formation, which is the most dreaded complication. As you see here, you have a full thickness retinal break. Oh, and if you have a retinal blood vessel crossing this retinal break, it will be ruptured, and this may cause vitreous hemorrhage. And you can have just avulsion of the retinal vessels. You know, there's a strong adhesion of the vitreous to the big blood vessels. So when they try to detach, it may cause avulsion of the vessels, and this may also cause some vitreous hemorrhage. It may be very little vitreous hemorrhage causing just some flying flies, or it may just obscure the whole vision, as you see here. So vitreous hemorrhage is, please don't forget this, is one of the important complications of PVD. So vitreal macular traction, I told you before, this may occur if it doesn't detach from the foveal area, and this may cause sudden decrease or metamorphopsia of the, which means that you see the lines broken or wavy, or you can see the object smaller than it is or larger than it is, micropsia and macropsia. All these things are called metamorphopsia. So any problem in the macular area cause metamorphopsia. So this vitreal macular traction may also cause metamorphopsia. And following this, a macular hole may appear, as you see here. A piece of retinal tissue is just taken from the macular area, forming a macular hole. And you can see it ophthalmoscopically too. And another complication is, while detaching the posterior hyaloid membrane, a thin layer of the posterior hyaloid may remain over the macular area, and within months or years, that layer may become thicker, forming color, as you see it in here as a colored membrane. It may cause a thick membrane, causing wrinkling of the fovea, deforming the fovea, and you can also see it ophthalmoscopically if it is thick enough. So this may cause not a sudden but very gradual, slow deterioration of vision. So these are the complications of vitreomacular traction, posterior vitreous detachment, sorry. And as I told you before, there are some peripheral retinal degenerations. These degenerations are usually in the peripheral part, as you see here, in very close to ora serrata. This is the central part. If you look just to the central part, you don't see them. If you want to see, if you're searching for these retinal degenerations, you have to look at the very periphery of the retina. And this is the lattice degeneration, which is the most dangerous of these degenerations. You see white blood vessel-like linings, and you can also see the hyperpigmented areas around it. This is very typical lattice degeneration. In these areas, retina is very thin, and vitreoretinal adhesion is also very strong here. So when there's a PVD, it may cause a retinal break formation in these areas. And they may cause, as you see here, horseshoe-like tears, as you see here, here, and here. Horseshoe tears are the most dangerous retinal breaks, which will lead to retinal detachment within days. So when we see a retinal break like this, horseshoe tear, we have to do laser as soon as possible. It's something like an urgent, emergent thing for us. We have to do laser for this. But there may also be some atrophic holes. As you see here, these are small atrophic holes, which occurs secondary to atrophy of the tint retinal areas. These are also important, and this may also lead to retinal detachment formation. However, it's not an urgent thing like horseshoe tear. So we also suggest prophylaxis for these retinal holes areas and retinal break areas, retinal degeneration areas, but it's not an urgent thing. But horseshoe tears are very dangerous. We have to do it very early. So we know that in myopic eyes, retinal detachment occurs more. Why? This is the reason. Although those lattice degenerations are seen in normal population, like 3 to 4%, but it is much more common, like 40%, 50% in myopic cases, in high myopic myopes. So this is one of the reasons. And vitreous degeneration, as you have already heard, and posterior vitreous detachment occurs more earlier in myopic eyes. And since the anteroposterior diameter of the retina, diameter of the eye is larger than normal, the retina becomes thinner when it gets larger. So that's why it's more prone to retinal detachment. So 40% of retinal detachments occur in myopic eyes. When we look at the retinal breaks, the horseshoe-like tears are the most common tear type leading to retinal detachment. And these retinal tears are usually symptomatic. They are usually together with photopsia and floaters symptoms. The retinal holes are usually asymptomatic. You usually find them accidentally during routine peripheral retinal examination. But these horseshoe-shaped tears usually comes to you with photopsia and floaters symptoms. So, and when they have a retinal vessel crossing that retinal break area, they may have some ruptured blood vessels causing some blurring of the vision because of those red blood cells flying in the vitreous. So these retinal breaks are usually symptomatic. So what do we do for these retinal breaks? When we see a retinal horseshoe tear, we have to do argon laser photocoagulation around the break. We stimulate wound healing around it, which causes fibrosis and strong adhesion of the retina to the choroid so that it doesn't detach. And there are some other retinal, I talked about the horseshoe-shaped tears and atrophic holes, but there is one more type of retinal break, which is called retinal disinsertion or dialysis, retinal dialysis type retinal break. As you see here, it is the disinsertion of the retina from the insertion site, which is ora serrata, as you see here. There's no flap over it. And this type of retinal break usually occurs in the inferior side, usually inferior temporal side, and it's more common after trauma. And since the trauma is the most common cause of retinal detachment in pediatric age group, because there's no PVD in pediatric age group, so this is the most common type of retinal break in pediatric eyes, the retinal dialysis type retinal breaks. So in trauma, you know, because of the induced PVD, retinal detachment is much more common. 10% of all retinal detachments occurs following trauma, and it's the most common cause of retinal detachment in children. And in penetrating injuries, both Rheumatogenes and Directional retinal detachment occurs. This is because of in the penetration side of the eye, you can see you can have a retinal break in the penetration side, but also you can have a granulation tissue, which is very strong with the choroid, sclera, and every layer is involved. That granulation tissue may cause formation of membranes, causing traction of the retina, causing tractional retinal detachment. So when we have a pediatric Rheumatogenes retinal detachment, we should ask first about trauma if patient has any trauma. But believe me, most of the pediatric cases, there's no trauma. They don't remember because they fall down and then come up and they forget about it. They don't say anything to their parents, but that trauma may have caused retinal break in their eyes. And since it's usually unilateral, and since it's the children, so they don't remember, they don't feel, and they lose one of the eyes, but the parents also does not realize because the fellow eye is okay, so they usually come very late with that retinal detachment, unfortunately. And prematurity is very important. In prematures, Rheumatogenes retinal detachment is very much more prevalent. You should also ask for the family history because some genetic diseases like Marfan syndrome, Stickler syndrome, they are autosomal dominant diseases, and you usually have some family history. And congenital developmental abnormalities like choroidal coloboma, as you see in this picture, cause retinal detachment. This was a choroidal coloboma, and it ended up with retinal detachment, as you see here. And we should also ask for post-ocular surgeries like congenital cataract, ophthalmos, which is congenital glaucoma, or vitrectomy surgeries. This is the animation of Rheumatogenes retinal detachment. As you see, PVD occurs, and it leads to a horseshoe-shaped retinal break, and vitreous goes underneath, causing retinal detachment. So the first signs of the retinal detachment is actually the signs of PVD, which is photopsia and floaters. They usually come with this symptoms. They say that I had some photopsia and floaters. There were millions of them in my view. I thought it will go away, so I didn't come to you. But 10 days, they say, it was like 2-3 weeks ago. Then a peripheral visual field effect, like a black curtain on one side of the eye, may start. Like in this picture, it depends on where the retinal break is. If it is in the inferior part, they start to feel the curtain from the superior side, for example, just the reverse, you know. So they can feel the black curtain coming from one side. You see the floaters, but if the retinal detachment does not come to macular area, the visual acuity is just full. So no visual problem, but just visual field problem starts. And within days, it progresses and it it involves the macular area, then they say that now I don't see anything. So it starts with photopsia and floaters 2-3 weeks before, and then a black curtain coming from one part of the visual field, and when it affects the fovea, then it's totally gone. So this is very typical. Please don't forget this, because even if you listen this with the phone call or anything, you can recognize that this is a retinal detachment symptom. So you can understand. You can diagnose even with the phone. And when you look at the retina, it's usually the convex surfaces. And the retina becomes whiter because it is away from the choroid, which gives the red color to the retina. It's a semi-transparent structure, the retina, and the surfaces are colored, and the retina is usually movable. And as you see here, the superior retina is detached, but it didn't become billows like in the previous one. It's like an orange, you know, as you see, it's like an orange. And as you see here, it comes and involves the macular area. So this patient comes with the inferior visual field defect first, and then since macular is detached, they say now my view has already totally gone. So this is another retinal detachment with multiple retinal breaks. As you see, they are all horseshoe shaped, very typical. And another retinal break with giant retinal break, and another giant retinal break where the retina is folded over. So as you see, retinal detachment occurs normally acutely. It causes an acute retinal, acute visual loss. But some of the retinal detachments become chronic because the patient does not feel it. This is the case mostly in inferior retinal detachment. As you see in this diagram, there's an inferior retinal detachment. This patient usually comes to you with the superior visual field defect. But since the macula is on, so their vision may be full, 10/10. But the visual field in the superior part is totally lost. So there are something different in this picture, as you see here. There is a pigmented line, as you see here, in the border of the retinal detachment. So why is it so? This is because of the chronicity. It's a sign of chronicity. When the retinal detachment is at that level for a long time, then the retina pigment epithelium in the detached area moves towards the limits of the retinal borders of the retinal detachment, and they form that pigmented line, which is called demarcation line. It's a sign of chronicity. Another sign is the intraretinal, in the sensorial retina, intraretinal cyst, which is another sign of chronic retinal detachment. So why do you think it's a chronic one? Why it didn't involve all the retina within days, which is normally expected? This is because this is an inferior retinal detachment. Inferior retinal detachment progression, since the progression is against the gravity, it's a slow process. And especially if it is caused by a very small retinal hole like this, it progresses very slowly first. And another thing, patient does not feel it. Since it is in the superior visual field, our superior visual field is, you know, much narrower than the inferior visual field. We can feel the very peripheral of inferior our visual field because it's a very large one, wide one. But the superior visual field is narrowed because of our eyebrows and all those things. So because of that. Second thing is that our inferior visual field is used routinely, actively by us, but while walking for anything, you know. But the superior visual field does not disturb us, you know, even if there's even if there is some problem in the superior visual field, it doesn't disturb us. So we may not feel it until it comes very close to our central visual field. So because of these reasons, inferior retinal detachments may come with the chronic retinal detachment, as you see here. When it comes too late, as you see here, there are some membranes, some contractile membranes which are formed by retina pigment epithelium under the retina or over the retina forms, which we call as proliferative vitreoretinopathy. This is our, very, very big problem in our fight for retinal detachment. PVR is caused by proliferation of retinal pigment epithelial cells and gliotic cells. They form contractile membranes over or under the retina, causing a contraction of the retina, and this prevents reattachment of retina in most of the cases. This is seen in long-term retinal detachments, giant and multiple number of retinal breaks, if there are, and it can be seen in penetrating injuries, or since it causes some granulation tissue, and if there is a vitreous hemorrhage may also have some fibrotic gliotic cells, and also even if there is no risk factors like this, in fast wound healers, which is just constitutional thing, you can have keloid-like wound healing, and it forms membranes causing PVR. So in this picture, you see a little PVR causing some wrinkling of retina, but retina is still mobile. But here you see some more wrinkling of the retina in these white bars, some membrane formation, and this is more PVR. As you see, even the edges of the retinal break are wrinkled, folded, and some wrinkles. So these are not good signs. These are PVR. So what to do when we have a retinal detachment? The best thing is to do the prophylaxis. This is very important. So we should do the laser prophylaxis. We should first examine the peripheral retina in all the eyes with acute PVD symptoms like photopsia and floaters. Please look at the peripheral retina. And if you see any retinal break, or if you see any lattice degeneration, do the laser photocoagulation. But also patients with high myopia, with a blunt trauma, or any family history with retinal detachment, or if there's a retinal detachment in the fellow eye, we should do regular detailed fundus examination, retinal examination in these eyes if there is any retinal break or retinal degeneration. So we should do the laser in these eyes if we see a retinal break. So this is the prophylaxis. So what we do if we have a retinal detachment? We have two kinds of approach. The main one is, the best one is, if we can do, is external retinopaxy, which is the classical retinal detachment surgery technique. It keeps the vitreous in its place. So this can be done only in fresh retinal detachments. And if there is PVR or late retinal detachment, we have to do internal retinopaxy by doing pars plana vitrectomy. So I will talk about these things. First of all, the scleral buckling, which is the external scleral retinopexy. Scleral buckling is done to fresh retinal detachments with 1 or 2 retinal breaks. So it shouldn't be a complicated retinal detachment. As you see here, we drain the subretinal fluid by doing a sclerotomy, and then we find the retinal break area, and we put an external buckle, scleral buckle, which is a sponge-like thing or silicone band, something like that. So we put it over it, we indent the sclera a bit, buckle the sclera, so that anything pulling the retina inside will be the counter force will be done by this scleral buckling. And we also do the cryo or laser to the retinal break area. So this is, to make it more clear, you see when we do a scleral buckle to the retinal break area and then drain the subretinal fluid, we do the cryo, then it's all in place. This is a surgical approach for the scleral buckling, which is external retinopaxy. We measure like 12 millimeter from the limbus, which shows the equator of the globe. And then we, as you see here, this is a silicone encircling material. So we fix it to the sclera with the sutures, and then we take these under the rectus muscles so that it doesn't affect the function of the rectus muscles. And then we drain the subretinal fluid, as you see here, by doing a sclerotomy. This fluid is the subretinal fluid coming from the subretinal area, and then after draining the fluid, you see we find the retinal break area, as you see here, do a cryotherapy. This cryotherapy, like laser, does not stick it suddenly. It stimulates a wound healing process, which takes part within 10 to 15 days. It produces a fibrosis causing adhesion of the retina to the choroid. So it takes some parts. During that 10-15 days period, that scleral buckle pushes the retina towards the retina pigmented epithelium so that it forms this scar tissue. You see the indentation from inside, and this is the scar tissue caused by cryo to the retinal break area. So we can, the first one is the scleral buckling or external retinopexy. And if we can do this, it's very easy, just one procedure. And if we can do that, the improvements period, healing period is much quick, and you don't have to do anything else. The vitreous is still there. But if there's a vitreous hemorrhage associated or PVR, if there's an old retinal detachment, if you have multiple giant retinal bays or macular holes, we have to do vitrectomy. With vitrectomy, what do? We enter the eye from pars plana with 3 entries, with 3 sclerotomies. From one entry, which the pars plana is the 3 to 4 millimeter from the limbus, the posterior to the limbus. From the first one, we put an infusion line giving the balanced salt solution into the eye, which is very near to aqueous humor constitution. And in the second one, we put a light probe, and in the third one, we put a vitrectomy probe. This vitrectomy probe absorbs the vacuums to retina, but there is an opening at the tip. It vacuums the vitreous, but there is a guillotine-like knife in it, which comes in, go in and out all the time, doing some cutting of the vitreous. It vacuums and cuts at the same time, so very, very fastly, so that it doesn't pull the retina together with vitreous. So this is the vitrectomy. So how we do that, you can see it in this video. This is a superior bullous retinal detachment. As you see here, we do a vitrectomy. You don't see the retinal break now, but you will see it somewhere here. And retina is mobile, as you see here, very mobile, bullous. The convex surfaces are seen. And when we do the vitrectomy, we have to do vitrectomy all over the areas. You see the retinal break area. When we resorb the vacuum, the subretinal fluid, retina goes backwards. So it's now it is attached, but we have to remove all the vitreous. Otherwise, when you leave some part of the vitreous, it will cause PVR formation, recurrence of the retinal detachment. But since you have removed the vitreous, you have to put something to support the retina during the wound healing process. We will do laser to the retinal break area, but we need something to support. This is usually gas, which is a tamponade for SF6 or C3F8 gas are used to tamponate the vitreous. And when there is gas in the eye doesn't see, but it resolves within 1-2 months spontaneously. You don't need to remove it with a new surgery. But gas is a very good tamponade for superior retinal detachment, but not for inferior retinal detachment or PVR cases. As you see here, if there is a PVR or if there is inferior retinal break, we need to put a silicone oil tamponade. As you see here, there are some subretinal membranes and preretinal membranes causing wrinkling of retina. These are real, very significant PVR membrane formations. We have to remove all these membranes very, very elegantly. Otherwise, it may cause new retinal break formations. So we have to do this one by one. And then after relieving, this is the original retinal break area. So we have to clear all those areas. Then also there are some subretinal membranes, as you see here. We need to remove those membranes by doing a small retinotomy, small retinal breaks. Otherwise, the retina cannot go in its normal place. Macula was almost over the optic nerve head area. Now it's coming to normal side, peeling all the membranes, and then we put silicone oil here, as you see here. But you have to remove that silicone oil within 3 months with another surgery. So this is something, additional. So if the macula is not involved with the retinal detachment, visual acuity may be full. It may just revert to the back. So visual field is usually complete. But if the macula is detached, the post-visual acuity will increase, but may be less than full, and some metamorphopsia may be present, may remain. And surgical success with one surgery is around 90 to 95% in fresh retinal detachment cases, but it's much less if there is some PVR. So till this part, I talked about the tractional Rheumatogenes retinal detachment. Now I will talk about the tractional retinal detachment. Tractional retinal detachments is usually caused by some traction pulling the retina. These are usually, as I told you before, caused by ischemic retinal vascular disease like proliferative diabetic retinopathy, retinal vein occlusions, sickle cell anemia, or vasculitis causing occlusion of retinal vessels. And this occlusion will lead to ischemia of some peripheral retina. And then that peripheral retina secretes vascular endothelial growth factor, VEGF, which stimulates new retinal vessel formation, which is called neovascularization. These neovascularizations start to form fibrosis. So they become fibrovascular membranes and they start to contract. And when they contract, they pull the retina. So, and as you see here, they pull the retina. And they usually originate from the previous retinal vascular sites so that you see those membranes more around the arcuate vessels or optic nerve head area. It's much less in the macular area because there is almost no retinal vessel, as you know, in the macular area. But those membranes will progress towards the macular area and will cause macular traction. But this is a very chronic and slow process. The ischemic retinal vascular diseases are not the only things, but we can have the penetrating trauma causing some membranes from the granulation tissue, and we can also have some neonatal tractional retinal detachment. I will talk about these things. First of all, the clinical picture is different in tractional retinal detachment. So there is no PVD and there is no retinal break. And so retina is not mobile like in, and the surfaces are not convex like in Rheumatogenes retinal detachment. So the surfaces are concave, as you see here, and there are some hills, which are the most traction areas, and there are some valleys in between, like in macular areas. So this vertical retina is not mobile, and very rarely these tractions, with long traction periods, they may cause some retinal breaks, rarely in ischemic areas, and then this may lead to combined traction and Rheumatogenes retinal detachments in these eyes. So there is no photopsia or floaters. Visual loss is slow. It's a chronic disease. It's not like in Rheumatogenes retinal detachment, and the treatment is only by vitrectomy. Now here in this video, you can see a vitrectomy for a proliferative diabetic retinopathy, and there's membranes everywhere causing traction of the retinal detachment. And you have to remove those membranes from the retina very gently, very elegantly. Otherwise, it may cause retinal breaks, and you may just lose the eye. So you have to be very careful, continue very patiently. As you see here, you will see some retinal hemorrhages because these membranes are vascular membranes. When you cut them, it may cause retinal hemorrhages. And at the end, as you see here, retina becomes like this. So this is the surgery. And another cause of traction retinal detachment is penetrating trauma, as I told you. This is the penetration site. As you see, there is a granulation tissue here, and the retina is pulled towards that granulation area. So this is another case. This is the granulation tissue penetration area. This is the optic nerve. Macula. It should be normally here, but this yellowish part is macula. It's pulled towards the traction, the granulation area by traction, and these are all penetrating trauma-related tractional retinal detachments. So what about the neonatal tractional retinal detachments? This is one of the most important things in this lecture. Premature retinopathy or retinopathy of prematurity. We call in short as ROP. ROP is very important. All of you have to know this because it's a public health problem. It's a preventable cause of blindness, and if you do everything normally, regularly, in the normal order, then you can prevent this. But if you don't do that, you will have a blind baby starting from the babyhood, you know? So it's a very important public health problem. It's a vasoproliferative disease of the neonate, and the problem is this. You know, there's central retinal artery and vein. It starts to form in the fetal period. The first central retinal artery and vein forms, and then the branches start to form. And the center is optic nerve head, and it goes towards the periphery while the baby grows. But if the baby is born early, is a premature birth, then the peripheral retina is not vascularized then, because it normally reaches to the periphery by the end of 40 weeks of normal gestation. So when it is born prematurely, then the peripheral part stays avascular. And in this period, normally intrauterine period, oxygen level is much low and VEGF levels are high. But when there's a preterm baby, we have to give oxygen because their lungs are not mature yet. We have to give oxygen to keep them alive. So when there is more oxygen, then VEGF levels drops. Because of this, the dropping of VEGF levels, vascularization stops. And when vascularization stops, then this peripheral retina start first of all with the oxygen in the air is okay for it, but when the retina starts to mature within time, within weeks, it starts to secrete lots of VEGF, which cause pathological retinal vessel formation in the border between the avascular and vascular retina, which is called the rich area. You see there some new pathological vessels starts to form. This is very important. For this, we have to screen all the babies born less than 32 weeks of gestational age or 1,500 grams birth weight, because these are the highest risk babies, and we start to do the first fundus examination at the end of first month, because by that date they start to form new vessels, otherwise they don't. So we start our examinations, and we know that there's a classification for ROP. We have some zones. The first zone is zone 1 is the nearest part of the optic nerve head area. Zone 2 is the equatorial part. Zone 3 is the most peripheral part. We have some stages in the, we have a ridge, the neovascularization area. If it is just a line, it's called stage 1. If it is more proliferated tissue, it's stage 3, etc. So these are the zones of the disease. This is stage 1, just a white line in between the avascular retina and vascular retina. But when it proliferates, it is stage 3, as you see here. The fibrovascular tissue, neovascularization is like a fibrovascular tissue. This is the avascular, this is the vascularized retina. And when we see stage 3, then we start treatments like intravitreal anti-VEGF injection or argon laser treatment to those avascular areas so that they don't secrete more VEGF. But if we don't do that, or if it doesn't respond to our treatment, it may progress to stage 4, as you see here. In stage 4, we have some tractional retinal detachment starting. It's a partial tractional retinal detachment era. As you see here, this is the fundus appearance, although there are some laser scars here. It calls some tractional retinal detachment. What do? Is we have to do vitrectomy for such eyes, optic nerve, and this is macular area. Normally it should be somewhere here, but because of those membranes causing traction in the retina and macula are pulled towards that traction side, as you see from the optic nerve head also. So what we do is we do vitrectomy, just relieve those tractions, relieve those membranes, and so that retina goes to its normal site after you relieve those tractions normally. And if we don't do that at stage 4, it's okay. We can, if we do it at stage 4, it's okay. We can have good visual acuities. But if it comes to stage 5, the leukocory period, then it's equal to blindness. The retina is totally pulled towards the back of the lens, and it causes just leukocoria, as you see. We do operate some of these kids, but we don't expect any vision more than like light perception or maybe hand motions. If we are lucky, they may count fingers from half meter or so, not more than that. So it's a legal blindness. So we shouldn't let the stage 5 to occur. So that's the main message from ROP. Please, 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 whatever you become, ophthalmologist, pediatrist, obstetrics gynecologist, or general health practitioner, please, 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 if you see any premature baby, please make sure that they go to an ophthalmologist for the for the ROP screening before becoming late within 1 month. So, and this stage 5 appearance occurs within 2 months or so. It's very, very quick. So please don't forget. So another thing in pediatric eyes is persistent fetal vasculature. This is also very typical leukochorea causes, one of the leukochorea causes. This is caused by, as the name implies, persistence of fetal vasculature. Normally, in the intrauterine life, from the optic nerve head area, there's a hyaloid vessel, which is the precursor of central retinal artery and vein. Hyaloid vessel comes from the optic nerve head area, crosses the vitreous cavity, goes to back of the lens, and it supplies all the globe for some time. But by the end of 28 weeks of fetal age, then this hyaloid vessel regresses spontaneously because the retinal vessels and the other supplies has already formed. But in some of the babies, this hyaloid artery does not regress and it stays there, and it may form a fibrovascular membrane behind the lens, causing the leukochorea appearance, fibrovascular tissue behind the lens, and also the cataract of the lens. And also it may cause traction of the retina at the back of the lens in some of the babies. And we can see that with ultrasonography. But the typical presentation is like this. They usually come with unilateral microphthalmia. It's 90% is unilateral. They come with a small eye, and it's leukochoric. If you see a small eye with leukochorea, please think about this persistent fetal vasculature syndrome. And when you do the ultrasonography, you see this connection between the optic nerve head and the back of the lens. So this is very typical. So this is the back of the retina. When you open this leukochorea during surgery, you see the retina is also pulled towards the anterior side. If you don't operate these eyes, they become shrinked and deformed eyes. So it's better to do the vitrectomy. Although the visual expectations are low, depending on the severity of the disease, but as you see here, it's a posterior PV. The anterior part is not affected too much, but there is a connection in between. You see, we just cut that connection and make it short as possible, then relieve the retinal traction, then it may end up with this, as you see. In these babies, we have another problem. There is an amblyopia problem. We have to also fight with this amblyopia by covering the patching the fellow better eye 1 hour, 2 hours, 3 hours a day, then this eye does not become lazy. So we prevent this blindness by this way. And this is the post-op 5-year appearance of the same baby, and visual acuity is not bad, as you see here, 0.2. So these are spare eyes. They cannot be expected to become normalized, but in any case, if the fellow eye is lost, that eye is very, very important for us, even if it sees just very little, but it's important. This is a combined form, both anterior and posterior part is affected very severely. You see the posterior retina is almost totally detached in the central part, and this is the post-op appearance. As you see, the peripheral retina is also attached with this surgery. And this was the directional retinal detachment. Lastly, I will talk 10 minutes more about exudative retinal detachment. As you see here, we have both extraocular causes or ocular causes of exudative retinal detachment. As the name implies, the fluid comes from, the source of fluid is from the vessels. It is usually retinal vessels or choroidal vessels. So, in the extraocular causes, we have like malignant hypertension or hypertensive crisis caused by pheochromocytoma or eclampsia. So when you have a very high pressures, I'm talking about like 300 millimeter mercury. So it's very high blood pressures. So you don't expect this in routine, hypertensive cases. When the blood pressure increases too much, then the retinal blood vessel endothelium cannot stand to that pressure more, and it leaks. It leaks the serum from the retinal blood vessels towards the retina. Then it accumulates under the retina, and as you see here, they become bullous retinal detachments. It's an acute process. When you are asked to examine a pregnant eclampsia patient with the acute visual loss, you can think about this. So this may be an acute exudative retinal detachment caused by eclampsia. And in these cases, it's an acute process, but you can't do anything as an ophthalmologist. The cause must be resolved. Otherwise, you can't do anything. So when the hypertension is resolved, then the retinal pigment epithelial pump starts to work and pumps it, and the retina is attached spontaneously by itself. Another cause is the extraocular cause, ocular causes of retinal exudative retinal detachment. The main and very typical example for this exudative retinal detachment is Coats disease. Coats disease is a vascular disease, actually. It's a telangiectatic disease of the retinal vessels. It usually occurs in the temporal retina. Temporal retinal vessels become telangiectatic, and since the retinal vessel endothelium is not healthy, it leaks the serum of the blood, and in the early phases, you see just lipid accumulations in the retina, which is called hard exudates, and also some retinal edema. And if we can find, if we can detect the case at this stage, we just do laser to those telangiectatic vessels, and we can control the disease. But it's a lifelong disease. These exudations and these telangiectatic vessels may form in other vessels within time, so we have to follow the cases lifelong, and we have to do additional lasers and cryos or intravitreal anti-VEGF treatments lifelong. But it's very uncommon to find an early case like this. We usually don't see them at this age because it occurs in the first decade. So in children, that means that it's in children. In the first decade, and it occurs usually unilaterally. 90% is unilateral. That means that children usually do not realize that there's something going wrong in one of the eyes. The family also does not realize. That's why it's more in boys, by the way. First decade, more in boys, and mostly unilateral. They usually come like this when they are exudate, when they cause massive exudative retinal detachment coming back to the back of the lens, causing leukocoria. So this is another cause of leukocoria. The first one was ROP, second one was PFP, and the third one was, as you see here, Coats disease. This is a very severe form of Coats disease, of course. Not all of them are like this, but they usually come in the later stages with leukocoria or painful red eye, because within time, if they don't feel it, they come with this, and also the retina is not, becomes ischemic, it's not supplied, and retinal vessels becomes occluded. Then neovascular glaucoma starts, and that neovascular glaucoma causes painful red eye, and the eye have to be enucleated after that. Evisceration or enucleation has to be done. So we just want to prevent those enucleation, evisceration, painful red eye formation. In these stages, the visual expectations are very low. We just want to protect the eye. We do the surgery. We do retinal reattachment surgery for these eyes, but just to protect the eye from evisceration. So if you look at the fluorescein angiography, all of the retinal vessels are, as you see here, telangiectatic, and they leak from those vessels. So Coats disease is a very typical one. Another cause of exudative retinal detachment is choroidal tumors. As you see here, there is a retinal detachment. This is one of the lines, but there's another line here. What is that? This is the tumor area. And when you do the ultrasonography, you see the typical mushroom-shaped choroidal malignant melanoma associated with exudative retinal detachment. The source for the exudation is the pathological vessels of the tumor. So they leak some serum causing retinal detachment. So the treatment may be enucleation in this case. Another cause is uveitis. Some of the uveitis may cause leakage of retinal vessels because of the inflammation, and those leakage may lead to exudative retinal detachments. So for these cases, you need to do steroid treatment. So completely different treatments, as you see here. Another cause of exudative retinal detachment is central serous chorioretinopathy, which is a very typical disease, more common in young or middle-aged men who have A-type personality, which is more prone to stressful personality. It's usually induced by stress, and it usually spontaneously regresses within days or weeks. As you see here, there's just macular serous retinal detachment in the macular area. As you see here, the fluid accumulation is only in the macular area. So what they feel is, they feel a gray shadow in their central view. When you measure the visual acuity, it's like 0.8 or 0.9, 0.7, not too much. They can feel some metamorphopsia, you know, the deformed vision, but the visual acuity is not too bad at the beginning. And you can see where it leaks. They usually leak from the choroid. There's a retinal pigment epithelial defect, and it leaks from the choroidal vessels, and it causes some retinal detachment in the fovea. Then it recovers spontaneously. But some of those may become chronic or recurrent, too much, causing causing visual problems, and then we have to do some laser treatments to cure them. In general, exudative retinal detachments, there is no traction or retinal break, and the fluid leaks from retina, choroid, or retinal pigment epithelial defects. And very typical important thing is that it may move with gravity. The retinal detachment area move with gravity and the head movements. When they are in erect position, it's in the inferior part, and when you make them lie down in one side for some time, 1 or 2 hours, then when you look at it, the fluid comes to that side. This is very typical, and sometimes we use this just to make a differential diagnosis. This does not happen in Rheumatogenes or Directional retinal detachment. There's no photopsia, no floaters, there's no posterior vitreous detachment. Visual field defect usually occurs suddenly, and there's no surgical treatment for extraocular causes, at least, and we have to treat the underlying condition. Treatment depends on that. So this was all that I want to tell to you. I hope to see you soon after control of pandemia, face by face. And if you want to see more videos, surgical videos, and some more information, you can visit my website in www.shengülözdek.com. Have a good day.